Okay. Thank you everyone for coming to this conference, and thank you for the organizers for inviting me to Montreal, where I've never been before. I'm sorry this visit will be very short. I'm going to talk about lung carcinoids together with Dr. Sirva from Montreal here. The traditional management of patients with lung carcinoids has been first a long delay of diagnosis and then surgery and then a few years of chest x-ray and then go home and be cured. Nowadays, we have learned more about these tumors, so the management has changed somewhat. Let me see if I can have the next. This is a picture of a bronchoscopic view of a lung carcinoids filling out the main bronchus. Neuroendocrine lung carcinoids have traditionally been divided into typical and atypical carcinoids, large cell lung cancer and small cell lung cancer. And we're not going to talk about large and small cell lung cancer. The definitions of typical carcinoids have been varying. The previous definition was based on histological criteria, and it was dating from 1972 by Aragoni. The modern WHIO definition is based on a paper by William D. Travis from 1998, where typical carcinoids should have less than 2 mitosis per 10 high power fields. Necrosis are not allowed, while typical carcinoids have between 2 and 10 mitosis per 10 high power fields, and they may also contain necrosis. This is a picture of a typical carcinoid in the hematoxylin stain. You can see the very silent growth pattern. This is an uncommon tumor, although the incidence is increasing. It's about 0.7 per 10.5. All age groups are affected, even children, where it's the most common tumor. However, the peak incidence is around middle ages. Women are slightly more affected than men. The etiology for this disease is unknown. There is so far no proven relation to smoking, but the incidence is increased in patients with multiple endocrine neoplasia type 1. And those patients also can have other foregut tumors such as thymic carcinoids, duodenal carcinoids, and gastric carcinoids. The pathology, these tumors are neuroendocrine, and thus they stain positive for the neuroendocrine markers chromogranin A and synaptophysin, as well as for cytokeratin because they are epithelial in origin. The serotonin stain is used to differentiate between foregut and midgut tumor when the biopsy is taken from a metastasis or when you suspect that the lung tumor is a metastasis. Although lung carcinoids may stain positive for serotonin, the staining is usually less intense than in a small bowel carcinoids. The Ki67 or MIB1 should always be performed in these tumors. The proliferative rate is important and has a definite impact on the kind of treatment in patients with metastatic tumors. I also recommend that you stain for CD44, which is an adhesion molecule, and it has prognostic implications in patients with no known metastases. And I will come back to that. This is a typically lung carcinoids with strong positive chromogranin A staining. Typical carcinoids metastases in about 5 to 20%, and atypical carcinoids in a much higher frequency, as high as up to 70%, according to the original paper by Aragoni. And the most common localization for metastasis is, of course, the lymph nodes, but they can also metastasize distantly to the liver, bones, brain, skin, mammary gland, or even eyes. Many of these patients are asymptomatic and detected by chance on chest X-ray for unrelated lesion, for example, as investigation for hypertension or as a preoperative investigation. Common symptoms include cough, hemoptysis, dyspnea, wheezing, recurrent pneumonias with remaining infiltrates on chest X-ray or CT scan. Chest pain is also common symptoms. And you can see that some of these symptoms can easily be misinterpreted, and that is why the diagnosis is often missed for many years. They are often diagnosed as asthmatic patients and receive treatment for asthma during many years. I mean, pneumonias, antibiotics, go home, and they are better, and then they have a new pneumonia, okay, new antibiotic. You should be aware that patients with recurrent pneumonias, and especially if there is a remaining infiltrate, may have a carcinoid, and they should be referred for bronchoscopy or CT scan. Endocrine symptoms are uncommon in these patients, and they occur only in a few percentage of patients. And when I come to the diagnosis, I will tell you what to test for. Cushing syndrome with due to production of adrenocorticotropic hormone or corticotropin-releasing factor with overproduction of cortisol from the adrenals may occur. And it may occur even if the tumor is not metastatic. The carcinoid syndrome, which we already have heard about, with flush, diarrhea, and so forth, is uncommon and usually seen only in patients with metastatic tumors. And it's caused by serotonin production. The atypical carcinoid syndrome, due to histamine overproduction with generalized flushing, edemas, asthma, swelling of the eyelids, and swelling of the lips, is also very uncommon, but it may occur in patients with metastatic tumors. And acromegaly is really uncommon. It's due to secretion of growth hormone-releasing hormone. It's described in the literature, but it's rare. Well, diagnosis. About 50 to 60% of these tumors are visible on a common plain chest X-ray. But you should always have a CT or an MRI scan of the thorax because you need to look for the extent of the tumor and also for enlarged lymph nodes to facilitate for the surgeons, and you will hear more about that in a few minutes. Bronchoscopy plus biopsy. Well, the tumors may be either central or peripheral. The central tumors are usually accessible by bronchoscopy, which we always will hear about a few minutes later. There has been a debate about whether it's safe or not to biopsy these tumors. The common opinion is that they may be biopsied safely. I have omitted transthoracic biopsy. Previously, I had it within brackets. I think that transthoracic biopsy is doubtful because of risk for misinterpretation. Instead, I think that the tumor should be taken out. Whether octreoscan or not should be performed, there are different opinions. My opinion is that it should definitely be performed in all patients because you want to know if the tumor is positive on octreoscan, and thus if octreoscan is a method that can be used for following up of these patients. Roughly 2/3 of these tumors are octreoscan positive, and thus it's important to know if this is a valuable method. In certain cases, very selected cases, PET, and then PET with 5-hydroxytryptophan may be indicated, especially if you have, for example, an ectopic Cushing syndrome where you can't find the primary, or where there is a suspicion of remaining or recurrent disease, small diseases, small metastases, their PET can be valuable. This is probably, although no comparative studies have been done, the most sensitive method for detection of remaining or recurrent small tumors. Biochemistry. I think that you should check for plasma chromogranin A in these patients, not because it's elevated in many of them, but if plasma chromogranin A is elevated, this indicates that the tumor is already metastatic, and then you should really try to intensify your search for metastatic disease or tumors outside the thorax. I have omitted urinary 5-HIAA and plasma cortisol in this list. Previously, I had it within brackets. And the reason is that I don't think it should be taken routinely. If you have a clinical suspicion of a carcinoid syndrome, you should, of course, test for 5-HIAA. If you have a clinical suspicion of a Cushing syndrome, you should test for urinary cortisol and plasma adrenocorticotropic hormones. If you don't have a clinical suspicion, it's just waste of money, and I think you should spend your resources on better things. This is an Octria scan of a typical lung carcinoid. Let me see. Yes, really positive. I don't have the microphone, but you can see it. Oh, sorry. And this is the same patient where the tumor is clearly visible on the CT scan there. This was a PET scan, and this should have been a PET scan. But the problem is that I made it on the Mac, and then the picture was destroyed. I'm sorry for that. Normally I check it, but I forgot this. The treatment of these tumors consists of surgery, which is the mainstay, and we will hear about the surgery in a few minutes. Radiotherapy, chemotherapy, biotherapy, liver embolization, and symptomatic treatment. And now I will stop, and please, Dr. Sirois, can you talk about surgery, which is the only curative treatment?
Thank you. Bonjour à tous, welcome. I want to say thanks to the organizer of for the meeting to invite me to present. So I'm going to give you the point of view of the surgeon to treat the neuroendocrine tumor of the lung. So I always like to present a bit of history. So the first one you describe neuroendocrine tumor of the lung, carcinoid tumor, indeed was Laennec in 1830. And later on, about 100 years ago, a German pathologist, Oberdorfer, is the first one to describe the term carcinoid, was some tumor like a cancer, indeed, you know. So that at this time started the controversy about the fact if the carcinoid tumor is a true cancer or not, you know. Gosset and Masson in 1914 described the endocrine aspect of the carcinoid tumor, and later on Dreamer coined the term adenoma of the bronchus, which made more controversy even about the fact that if the tumor is malign or benign. So this is Laennec, who described carcinoid tumor of the bronchus, and Feiter in 1938 described the neuroendocrine tumor system. Pierce coined the term APUD that was discussed before, and Rigoni described the first time atypical carcinoid tumor. So it's a rare tumor, as Dr. Granberg well described, you know, so we don't see that very often. It's a tumor with a relatively indolent clinical behavior. It presents with a neuroendocrine differentiation, as you know. It's not a benign process. It's a cancer. I hope everybody in the room knows already now that those tumors can metastasize and you can die of it. The problem is the people not in this room. Many physicians and person think that those tumors are benign, and that's often a problem when the patient is referred to me. I have to explain to the patient that it's a cancer. It's a sort of a low-grade tumor, and this is very difficult to explain because often the patient has been said that you have a benign tumor, don't worry about that, everything will be fine. So it's very important the patient understand it's a cancer, so they have to come back and follow up after the surgery because this tumor can always come back. So it's about 1 or 2% of all lung malignancy are bronchial carcinoid, and for all the carcinoid tumor, 20 to 30% are originate in the lung. It's the most common tumor in the children, lung tumor in the children. And the age for the typical carcinoid is about 45 years old, and for the atypical carcinoid about 55 years old, a bit older. The incidence is rising, but we're not sure exactly why. Maybe it's just the fact that we have better tests to detect the tumor. It's unclear if smoking is an etiologic factor, and this has been associated with the multiple endocrine neoplasia, as Dr. Granberg explained to you. So there's different classification. Okay, the classic one is the WHO classification in 2004, and it started with the typical carcinoid tumor. You have also the atypical carcinoid tumor. You also have the large cell neuroendocrine lung cancer, which is indeed in the group of true lung cancer, and the small cell lung cancer. I'm not going to talk about the two last one because they are a special group of poor prognosis, but I'm going to talk about the typical and atypical carcinoid tumor. Histology, we already talked about it. I'm going to skip that. This is a slide of what a carcinoid tumor of the bronchus look like. You can have lymph node metastasis in about 5 to 20% in typical carcinoid tumor and about 30 to 70% in atypical carcinoid tumor. Clinical presentation. Dr. Granberg already told you about the sign quickly. Often the patient have cough, hemoptysis, and recurrent pneumonia in the same area. A patient with recurrent pneumonia, let's just see in the same right lower lobe, this has to raise this, ring a bell and raise suspicious for a possible tumor, such as a carcinoid tumor, and you need to do bronchoscopy or a CT scan. You can have chest pain and wheezing as well. Those are all the same tones. And often the patient are asymptomatic. Depending on the series, it's close to 50% of the patient are asymptomatic. The lesion was just found, seen on a chest X-ray as a routine. This masquerade other disease, as you know already, asthma and bronchitis. And as I said, some patients are asymptomatic. Okay, and also you can have hormone-related symptoms. This is very rare for bronchial carcinoid tumor, actually. It's less than 5%. You can see the frequent localization of the carcinoid tumor in the lung. And those are different series, recent series of bronchial carcinoid tumor. And you can see it's a rare tumor because the biggest series is about 140 patients in 2000. So you don't see a lot of those, maybe 3 or 4 a year, something like this. And carcinoid syndrome, I'm going to skip that slide because we talked about it earlier. It's very rare in bronchial carcinoid tumor. And you already know about the symptoms. And carcinoid crisis, we already talked about it. It's very rare. We don't need to give somatostatin prior to biopsy or surgery because it's so rare. And but if it happens, you can always give an injection of octreotide. Cushing syndrome is also another rare syndrome that can occur in about 1 to 2% of all bronchial carcinoid tumor. You can see the symptom here. And we think that the prognosis is slightly worse, but the treatment is the same. You try to remove the tumor surgically. The diagnosis can be done with chest X-ray, CT scan, MRI, PET scan, and octreotide scan, and bronchoscopy. So this, I'm going to skip that. As you see, it's kind of complex, but most of the time we find a nodule on the chest X-ray, we do a scan, we get the biopsy, and surgery is done. And you can see here the lesion on the chest X-ray and on the CT scan. So there's an abnormality in 3/4 of the patient on the chest X-ray. Can be just an opacity, or it can be also a mass, and you can have atelectasis or rarely a cavitary lesion. CT scan help us to determine the exact localization of the tumor, the size, and if there's presence of lymph node metastasis. Classically, those tumors are enhanced, with contrast injection, and you can also have classically eccentric calcification, or possible. And again, another image of the CT scan here. At bronchoscopy, the tumor is often found in 3/4 of the patient, and it's a typical pink or red smooth mass, and often there's a broad base attachment to the bronchus. There's also a ball valve effect. That means that air goes in the lobe or in the lung, but cannot get out, so the lung inflates. You have a hyperinflation of the lung. It's a classic finding. Biopsy, it is safe. In the past, they used to say that you could have a massive hemoptysis with biopsy. Well, now these days, if we take just a little, not a too big piece, but a fairly small piece, and you inject epinephrine solution prior to do the biopsy and after, it's very rare that you would have a complication or problem. Although, if the tumor is so typical of carcinoma tumor, often you don't even need a biopsy and you go right to surgery. So it's controversial. I often operate patients just on the classic appearance, and without a biopsy. This is a classic finding on the bronchoscopy. And the treatment on this diagram seems a bit different, typical or atypical, but mainly you try to remove the tumor as much as possible. So surgery is a main goal, treatment goal. So you have surgical resection. You can do endoscopic resection, and the other treatment will be discussed later by Dr. Granberg. So surgical resection, treatment of choice. Okay, it's the only chance of real cure. You want to do an en bloc resection of the anterior tumor. That means you try to remove the tumor en bloc, like one piece. You don't cut piecemeal. You don't want to try to remove the whole thing at once. And the goal is also to keep as much lung as possible. You don't want to remove the whole lung. If possible, you want to try to keep some lobe. The type of surgery we can do a lobectomy. That's a classic procedure. You can also do a bronchoplasty or sleeve. That means you cut the bronchus and you reconnect the bronchus after that. You can do segmentectomy. It's a segment of a lobe. You can do a wedge. It's remove a little piece of the lung, actually. You can do a pneumonectomy, which is removing the whole lung, and a bronchotomy. You cut the bronchus and you remove the tumor and you close the bronchus after. So you can see the right and left lung, and there's different segments. So basically, you can remove all sort of combination. You could remove a whole lobe or a different segment. So yeah, of course, you have to be familiar with the anatomy, and it depends where the tumor is. So in this, for the bronchial carcinoma tumor, you could in fact do sleeve resection because you don't need a fairly large margin of resection. Margin of resection is how far you cut to the tumor. So you can accept like 5 millimeters, sometimes even less, because there's no submucosal spread of the tumor compared to a classic lung cancer. So you can achieve resection with a very good result with a very minimal margin of resection. So you can cut a piece of the lung and reconnect the bronchus. We call that a sleeve resection. You can see here there's also the combination of sleeve or bronchoplasty. You can reconnect after that the bronchus. Okay, obviously it depends where the tumor is. And but the traditional surgery is the formal lobectomy. Okay, because you can remove the lymphatic drainage. It's very important that you have to do a lymph node dissection. It's very important to remove all the lymph node for staging, to know if the tumor has spread or not, and also as a cure to remove all gross disease. Even if there's metastasis, you try to remove as much as possible the gross disease of the lymph node. And this is the Toronto experience. They have about 11% of pneumonectomy. Lobectomy was about 65-70%. And you have also segmentectomy wedge, about 10%. So surgery can be done classically by a thoracotomy, either a conventional thoracotomy or more limited thoracotomy. Can be done by thoracoscopy, VATS means video-assisted thoracoscopic surgery, or hybrid fashion, a mini thoracotomy with a telescope. So this is a thoracotomy, give you a good exposure. You don't hesitate to make a good incision if you need to do a proper curative oncologic surgery. If you want to remove a lymph node, sometimes it's easier by a good incision. You can also use a small telescope like this. We call that a thoracoscope, and it's attached on a camera. And you can resect part of the lobe like a lobectomy or a smaller piece, a wedge, with small incision. But the limiting factor with thoracoscopy is the lymph node dissection. It's very difficult to remove the lymph node by thoracoscopy. So another way to approach this problem is to do a hybrid technique. You do a mini thoracotomy with a telescope. So you don't do a huge incision, do small incision, less pain, but you do a good lymph node dissection. Lymph node dissection, as I mentioned, is very important. You can just do a sampling. You take a few nodes, or you can try to remove all the lymph nodes. There's different modifications. It's too complicated to explain that today, but you can also do an extensive lymphadenectomy like it's done in Japan. But usually we do a complete dissection. So you should try to remove as much microscopic disease as possible. As you can see here, it's a bit complex, all the lymph node mapping. Every node has an area and there's a number to it. Surgical outcome, the mortality is extremely low. Lobectomy is less than 1%. Pneumonectomy is about 2-3%, even less these days. It's close to well below 1% in 2009. Those were the number in 2002, and the mortality was already below 1%. So just to finish, we can also do endobronchial management. So we can remove the tumor by a bronchoscopy. It's a tube going through the mouth or the nose into the airways. And we call that a flexible or rigid bronchoscopy. And you can do a biopsy, obviously. You can do laser or photodynamic therapy. And it's controversial if this is adequate treatment. It's not considered like a true curative, but we perform this approach for a patient who are poor surgical candidate, or a patient who had metastatic disease, but you want to do it for a palliative point of view. You have to stop the bleeding or open up the bronchus so the patient don't get pneumonia. And you can also do it temporarily as a bridge to do a resection later on. For instance, if you have a woman, a pregnant woman who had a carcinoma tumor, you can open up the bronchus, prevent infection, and a year later you go back and you resect the residual tumor. So the prognosis is very good. Dr. Granberg was going to talk about it. So that's it.
Okay. Thank you, Dr. Sirwa. I must say that I agree completely with your therapeutic considerations about surgery there, and I'm very glad that you stressed the lymph node dissection and also that you pointed out that endobronchial treatment is rarely curative. I completely agree with those aspects. Now we're going to talk about when surgery is not enough, when the tumor is metastatic. Radiotherapy can be administered either as conventional radiotherapy against bone or brain metastasis. It may also be considered against the tumor area when surgery is not possible, for example, in very ill patients, or when there is an incomplete resection. When the resection margins are affected by tumor and the thoracic surgeon do not want to go in again. And also, in atypical carcinoids with lymph node metastasis, this is controversial, I must admit, but it can at least be considered. Targeted radiotherapy either with 177 lutetium or 9-to-yttrium octreotide is an alternative in patients with metastatic disease and somatostatin receptor positive tumors. Biotherapy, I must again mention alpha interferon, either as common interferon or PEG interferon, which can be used in patients with low proliferative tumors and metastatic disease. You adjust the dose according to tolerance and leukocyte count less than 3. Octreotide or lanreotide, as sandostatin LAR or lanreotide autogel may be preferably combined with interferon, or maybe after the PROMID study considered in low proliferative tumors if the patient is not expected to tolerate alpha interferon. Here are the results from my report in 2001. There were most patients had progressive disease on alpha interferon, but a few patients were stable, and we have seen some patients responding. Another study from Italy reporting about 2/3 stable disease on sandostatin and lanreotide. Chemotherapy has emerged as a good alternative in patients with metastatic lung carcinoids, and first line today, I must say, is temozolomide, either as monotherapy or combined with capecitabine and or Avastin. Other alternatives are streptozotocin plus 5-FU or doxorubicin, cisplatin, carboplatin, plus etoposide. This combination is mainly used in patients with very poorly differentiated tumors. And there are some other combinations that you can see, taxanes plus doxorubicin and so forth. This is a study by Sara Ekeblad from our institution in 2007, where 1/3 of patients with bronchial carcinoids had a partial response, 1/3 had stable disease, and 1/3 progressive disease on monotherapy with temozolomide, and about 70% of patients with thymic carcinoids were also stable. And these are rather interesting figures, I must say. This is my initial report from 31 patients, where there were a few patients responding to cisplatin and etoposide, and some patients also stable on other combinations of chemotherapy. This is another paper where you can see that there were a few patients responding to chemotherapy mostly on platinum-based chemotherapy. And this is a study only 2 years ago reported as an abstract where 34 patients with atypical metastatic carcinoids were treated, and overall response to first-line therapy was 32%, mostly to streptozotocin-based chemotherapy. And you can see that this is inconsistent with our results. These are better, and also a few patients responded to platinum-based chemotherapy. And there were also some patients responding to second-line chemo. Yes, and this is the same study by De Dosso. Also, 28 patients with metastatic lung carcinoids, and all of them received somatostatin analog as first-line treatment. And you can see that there were a few responses to chemotherapy, mainly Celox, which means oxaliplatin, and capecitabine, and also 5-FU dacarbazine plus epirubicin. When you consider chemotherapy to these patients, you have to remember that toxicity varies. Somatostatin analogs, as we have heard, are rather non-toxic, very few side effects. Interferon has many side effects, but also, in our experience, many patients tolerate it rather well. Chemotherapy, pardon? Oh, okay. Chemotherapy, depending on what you give, nausea, vomiting, asthenia, platinum, of course, can cause neuropathy, hematological side effect. You have to remember that monotherapy with temozolomide is rather non-toxic. Most of the patients treated with that feel very well. The main side effects are the hematologic toxicity, well, thrombocytopenia and leukoneutropenia. Lutetium octreotide therapy may be considered in patients with high uptake on octreoscan. The bone marrow and renal function must be rather normal. Leukocytes above 3, platelets above 100, and GFR more than 50 milliliters per minute. And we normally give 4 to 6 treatments with 6 to 8 weeks or 6 to 12 weeks interval, and the maximum dose is 7.4 gigabecquerel per treatment. And there were some results reported by the Dutch group, Kwekebom and co-workers, where 5 out of 9 patients had a partial response, 1 had a minor response, and 2 had stable disease, and median time to progression was 31 months, which are rather impressive results. We have so far treated 8 patients with bronchial carcinoids with lutetium, and 2 have had a partial response, 2 had minor response, and 4 had stable disease. And we have some additional patients we have not been able to evaluate yet. The quality of life is also important, and you can say that it's varying on interferon. It's usually good on somatostatin analogs. Patients on temozolomide have also usually a high quality of life, as well as patients on streptozotocin and 5-FU. However, the toxicity of cisplatin and carboplatin plus etoposide is high, as is the toxicity of taxane-based chemotherapy. And lutetium patients also usually feel very well, even better than after the initiation of therapy. The symptomatic treatment consists of, in Cushing syndrome, metyrapone, ketoconazole, and octreotide. The carcinoid syndrome is treated with octreotide, SC or IV, histamine 1 and 2 receptor blockers, steroids, and some patients with very severe carcinoid syndrome or atypical carcinoid syndrome may require interferon as symptomatic treatment. Newer therapies consist of the tyrosine kinase inhibitors, which we already heard about, imatinib, gefitinib, ilartinib, sorafenib, sunitinib, and vendetanib, the angiogenesis inhibitors, bevacizumab, which is Avastin or tipramod, and the mTOR inhibitors, everolimus, sirolimus, temsirolimus, which are experimental. This is a summary of treatment of patients with lung carcinoids. Patients with low proliferative rate should, that is Ki67 less than 2 to 3%, unless they are amenable to surgery, of course, metastatic patients. You may consider biotherapy with alpha interferon and also somatostatin analogs, chemotherapy with temozolomide, streptozotocin, and 5-FU, or peptide receptor radionuclear therapy with lutetium or yttrium. Intermediate proliferative activity patients, Ki67 5 to 10%, chemo, temozolomide, streptozotocin plus doxorubicin or 5-FU, or lutetium or yttrium, and patients with high proliferative rate should have platinum-based chemotherapy as first-line treatment, or maybe temozolomide combined with capecitabine and or bevacizumab. And the experimental treatments consist of everolimus and the tyrosine kinase inhibitors, or the angiogenesis inhibitors. The prognosis, as we have already heard, is usually good. The 5-year survival is excellent. Almost 100% of patients with typical carcinoids are cured by this guy, the surgeon. You do a good job. The survival is considerably less in patients with atypical carcinoids, but many of these are also cured by surgery, I must admit. And the 10-year survival is also excellent, primarily in patients with typical carcinoids. Prognostically unfavorable things: atypical carcinoid, lymph node metastasis at diagnosis, and high proliferative index, Ki67. And prognostically favorable positive CD44 staining. That's why I said that you should stain for CD44, and positive nuclear NM23 staining, which we don't routinely do. This is a patient with a typical lung carcinoids, and you can see the membranous CD44 staining. This patient did not recur. Finally, 2 slides about recommendations. How do I think you should manage these patients? Well, you should analyze plasma chromoglobin A preoperatively, mainly to look for metastatic disease. You should perform a trio scan preoperatively to see if this is a good method to follow the patients. Radical surgery, and we have heard about that, primary tumor, lymph node metastasis, frozen section, and you should stain with Ki67 and CD44. You must follow these patients for very long periods of time. Late recurrence are not so uncommon. They may recur, I've heard, up to 30 years after primary surgery. So long-term follow-up is mandatory. And you should pay increased attention to patients with high Ki67 index, lymph node metastasis at diagnosis, and negative CD44 stain. Typical carcinoid, radical surgery, long-term follow-up. Atypical carcinoid patients, also radical surgery. And in these patients, you should at least perform a lobectomy, I must say. I hope you agree. You agree. Thank you. You should consider radiotherapy if the surgery was not radical, and you must also, and if the surgery was not radical, maybe chemoradiotherapy, although there is no data about adjuvant chemotherapy in these patients. Close follow-up, at least 10 years, preferably more. I would like to thank the head of our department, Barbara Eriksson, Kjell Öberg, the founder, Ulrike Garsken, and Cecilia Wassberg, who helped me with some of the slides, and as well Anders Sundin and Richard Niemann also. And finally, I want to thank you for listening and inviting me. And this is our hospital. Thank you.